Number one reason for bankruptcy in the US today is healthcare costs. That can literally wipe you out. One time a year, you have a chance. Can you please pay us more for services so we can take care of more poor people? The ones that I'm finding that are successful are the ones that are really all in. No large health system going to say, yes, let's bring them on board. You need to do your customer discovery. Actually do it. Remember, the drivers for hospitals and healthcare systems is to make money.
Hi. Before we start our today's interview, I'd like to remind you that the war in Ukraine is still far from being over. Actually, as a matter of fact, right now is one of the most crucial times for the battle of Ukrainian independence and democracy. So we encourage everyone to please continue to support Ukrainians in any possible way, even harder than you did before. This is really important to us. And now let's get to digital health. Our old subscribers probably know that over the past year, we've done a lot of interviews all over Europe and Asia. And today we start the new chapter of our digital health interview series. We are in a new country, on a new continent. We're in the US, the most desirable country and market for most of the digital health startups around the world. The reasons for that are pretty obvious. The market is huge. The amount of capital is much higher than any other place in the world. And to be honest, healthcare system in the US is far from being perfect. So there's lots of room for improvement, especially for technological side. So that is why today in our next interviews, we'll try our best to learn, explore, research American healthcare system, how it adopts technology, and basically what you need to do in order to be successful in this market. So I'm super happy to introduce our today's guest. His name is Kevin Baumlin. Hi, Kevin.
Hi.
I think you're a perfect candidate to tell us more about healthcare system overall, since you've been working in this system for a really long time. And plus, you now work a lot with technology. So I guess you can tell us about the adoption process as well. So before we get to that, let's start traditionally with your short intro. Just a few words about your background. How did you end up being a Chief Medical Affairs Officer at the Science Center here in the amazing city of Philadelphia?
Thank you. Thank you, Alex, for having me. Philadelphia is an amazing city, everybody. Come visit, come invest, come create jobs here in Philadelphia. My career has been long as a physician and as an informaticist. I've been a doc for 30 plus years. And I started my training here in Philadelphia at Hahnemann Hospital when I was a grad student, and started working literally in the computer lab, writing what we used to call computer-assisted instruction way back then. And started a software company in the 80s, which was actually started in 1988.
Whoa.
On August 8th, interestingly. It was a failure, but I learned a lot from my lack of success on what it was to make a company while going through medical school. Wasn't the best idea I ever had, but I learned a lot. I'm a boarded clinical informaticist, as well as boarded in emergency medicine and a professor of emergency medicine, now retired. And I'm here at the Science Center because I want to affect change in the healthcare system from a different angle. As you may know, I tried politics and ran for U.S. Senate. That didn't work out so well. So now I'm trying on the private equity side, working with startups, working with a whole host of young, talented, and not so young as well, startups who really want to make a difference to our system here in the U.S. and make it better than it is now, and it needs a lot of improvement.
That's amazing. By the way, are you planning to go back to politics at some point?
No.
Okay. Still good.
That was a quick and short answer.
Still good experience, probably, right?
I think I can make, interestingly enough, more of a difference from this space.
Okay.
And I'm already starting to see some hopeful change, and I could change the dialogue and the conversation. I'm still present in the media, still trying to be a social change agent, to do it on the political front through policy. I tried. I feel like I made my commitment and really tried to change the dialogue, and I think there's other ways that people can make change as well.
That's really cool. Yeah, let's get to that question I mentioned in the introduction. Can you give us an overview of American healthcare system, how it works, who are the payers? What are the hospitals? Are they private? Are there private hospitals, or are they all public? And all that stuff. And I'm gonna ask some follow-up questions.
That's a lot of stuff. I give like multi-hour seminars on this, but to kind of give it a clear as I can overview, I like to say it's U.S. healthcare systems. And if people think about it that way, especially entrepreneurs, I think it's a little bit easier to dive in. So the first and biggest part of the U.S. healthcare systems, the biggest part is the commercial payer system. And that's 50 to 60% of the population gets their health insurance through their job. And that's usually pretty good insurance, meaning that it covers a lot of your prescriptions, your doctor's visits, your in-hospital costs. With copays and deductibles, and these copay and deductibles system is like carrots and sticks, if you will. So if you have like a really good job, and we're like Penn's right behind us over here. So if you work at Penn and you have great insurance and it covers all kinds of things, including your doctor visits, most of your hospitalizations, prescriptions are literally free without a copay if you go to Penn Pharmacy. Those are like the platinum level commercial plans, if you will. In the commercial world, in the world of jobs, some jobs don't have great health insurance, but they cover you when you're in hospital. So you don't literally go bankrupt if you have a really serious illness. But some of those plans will have high copays and deductibles, even as high as $5,000 to $8,000 a year. So you can do the math. If you're making $40,000 a year, that can literally wipe you out. That can be the only thing you have left over for your kids. And we're talking about having a 2-year-old. So for the 2-year-olds need a lot of stuff. If you're planning on $8,000 for your kid's stuff, and all of a sudden you got a major medical bill, that can, even though you have insurance, it can wipe you out. So part of my job is to figure out how we can decrease copays and deductibles, and how we could keep people well. So part of my job is working with commercial insurance companies to say, let's talk about wellness. Let's talk about keeping people healthy, health and care instead of just health care in the commercial space. Then there's Medicare, which is our plan, federalized plan, mainly for older adults and folks with disabilities. That's about 17%, somewhere 15, 17% of the population, ever increasing because, as you know, our population is aging. The silver tsunami, I'm lucky to be the last of the baby boomer generations. It kind of gives away my age. But as we all age, we're all getting ready to go, or in Social Security and Medicare plans. And those Medicare plans cover your health insurance. But remember, not all of it. There's plan A, B, C, D, E, F, G, lots of letters. The big ones are A, B, C, and D. And the C is a big topic right now because those are called Medicare Advantage plans. And those are plans that don't have copays and deductibles, which are very attractive to older adults because they don't have a lot of savings. They're on fixed incomes, right? So they're flocking to in droves. I think it's gone from like 10% to 60% of all Medicare coverage. And those are essentially like HMOs, if you will, maintenance managed care plans where the insurers work with Medicare and they get paid per person, if you will, and try and keep down the costs of care. There's a lot of entrepreneurs in that space looking at populations of people thinking, how can we do a better job of decreasing their costs of care and improving the quality of care? Value proposition is better. So those Medicare Advantage plans are really looking for entrepreneurs to help them care for wellness for older adults, keep them out of hospital, and keep them better. Maybe not necessarily making them live longer, maybe also thinking about how we can have a better end of life that's less costly. So that's Medicare. Then there's Medicaid, which is this weird, hard to understand combination of state-based and federal supported care. It's state-based care. Every state is different. It makes it super complicated for outsiders looking in because Medicaid in Pennsylvania is different than West Virginia, which is different than Florida. Different rules, regulations, even though they're New Jersey and Pennsylvania are next door to each other, don't necessarily play nice with how the dollars flow between each other. And that's very complicated for entrepreneurs to understand. And then there's exchanges, which are different state by state, which is kind of like commercial insurance companies working with people who don't have a lot of income to see what they can, so they can be covered as well. And then there's uninsured. People have literally no health insurance. They show up. I'm a retired emergency physician, show up at my doors saying, I need care. I say, happy to help you because that's my gig. But that's about 8 to as low as 3% of the population in Massachusetts to as much as 18%, averaging around 8% of the overall U.S. population. What's important from entrepreneurs in the exchange space and the no insurance space is those are consumers. They're direct-to-consumer potential populations. So if you have a really cool way of providing cheaper, more cost-effective healthcare, there's still 10% of the population where you can really have an impact. And remember, those people with high deductibles, they're always looking for low-cost solutions too. So 10% of whatever that is still a lot of money. So there's a lot of entrepreneurs who want to get into the space of direct-to-consumer because there's still a lot of money to be made there.
Interesting. If my company I work for is not covering the insurance, or I guess I don't have a job, and the state won't help me, how much it still would cost me to buy insurance, to pay for insurance myself?
So it can cost a lot of money. Even when you're on Medicare, it's up to $600, $650 a month per person, up to, depending on how much money you've earned during your life. But if you're on the exchange, you're still talking about hundreds of dollars to $1,000, $1,500 a month for health insurance, depending on how much tolerance you have for the deductible. What happens to a lot of young people your age, not my age, will opt for the lower monthly but high deductible because they think that they're invincible, right? They think, oh, what's going to happen to me? And what happens is the number one reason for bankruptcy in the U.S. today is healthcare costs, healthcare bills. Sad and pathetic, isn't it? It really is sad and pathetic. We shouldn't have a country, the wealthiest country in the world, essentially, put so many people in bankruptcy just because they went for care or had a catastrophic event. But it's there, and I could say with certainty that the majority of young people don't necessarily need it year to year, and then something happens. If you're a good saver and you set aside, like I have friends who are in the exchanges, they set aside $10,000 a year in a savings account, and they may be a small business of one or two. Say you run an interior design business, you have yourself and 2 employees. You set aside a bucket of money every year so you know you can handle the deductible, and you just let it keep growing year after year after year, and it becomes a savings account. Or you can have a healthcare savings account, which is a whole other topic of conversation. So it's doable, but if you have kids especially if you have more than one kid, it becomes essentially catastrophic because kids do what? They get sick, and if your plan doesn't cover your kid's hospitalization, if they have RSV and they have bad bronchitis or respiratory symptoms, it can really hit you hard. The good news is it's only up to a certain amount, then you're covered. The bad news is it's hard to catch up year over year. And it makes for a system that has a lot of stressors and not a lot of answers. My sort of take on it right now is I was always battling insurance companies because, I'm the emergency department, so we don't have the most resources. So we're saying, can you please pay us more for services so we can take care of more poor people? My take now is working with insurance companies, working with hospital executives, saying, hey, I have this really cool company, and they're going to help you bring down the cost of care for this population. Why don't you consider working with them? It's a win-win, right? If you're paying out less claims in dollars, insurance company, and hospital, if you're getting less unpaid visits from a population, isn't that good? Let's try and bring value to the equation from the outside instead of trying to look at it from the inside. So I choose to think that there's hope.
I really hope there is. All right. So what do you see as the most pressing issues that need to be addressed as soon as possible in the healthcare system?
To me, the most pressing issue is this whole concept of copays and deductibles. Because if you really think of it, it's a regressive tax. It affects essentially poor people disproportionately than wealthy people, right? So if someone has an income of $200,000 a year, a $5,000 deductible, it's something, but it's not going to make them bankrupt. It's not going to change their life. What are they going to do? Maybe go out to dinner a couple of times less per month? That's really not going to change their lives. Versus a $40,000 income earner who's got a kid, a $9,000 deductible is going to change their lives. So I really feel that that's the most important thing we as leaders in healthcare, we as leaders now on the outside group of leaders that can affect an important change. And also to figure out ways to bring lower cost quality healthcare to consumers so they don't even reach their deductible. So they don't need to go to the doctor, so that they can go to, I used to run urgent care centers, they can go to the urgent care center or the large pharmaceutical company or large companies' services, get quicker answers that are accurate and quality, but bring down the cost of their care so that they don't have to hit their deductibles in a major way. And then decrease bankruptcies, which is a great thing, so people can have better quality of life. Do it from a different angle, if you will.
All right. And you've mentioned a little bit already about the high cost of healthcare. Do you think, is it possible in general to make it more affordable and accessible? I
do. A big trend in healthcare right now is workforce, because during COVID, we lost a lot of myself included, a lot of doctors with the incredible stress of caring for patients with COVID. We lost a lot of nurses, and they feel dehumanized. They feel not rewarded. During COVID, like, people are banging pots and sending us pizza. We had a lot of pizza during COVID. But as soon as it was over, nobody cares. No one's sending ERs pizza. No one's like sending deli sandwiches and individually wrapped with little notes to us anymore. That's just doesn't happen. All they're left with is understaffed ERs, understaffed inpatient units, and the same amount of volume and the pressure of taking care of the same amount of sick patients. Because remember, the drivers for hospitals and healthcare system is to make money. That's what drives them, because they have a budget to make. When elective surgeries went away, hospitals freaked out, because that's how they make their dollars. That's how they provide. That's how they have the ability to provide services for other people who may not have the ability to pay, right? Because the dollars they make from the private insurance side, the commercial side, supplement and support the Medicaid, Medicare, and the non-paying people in the system. That's the only way it works in the U.S. Otherwise, without the commercial payers, everyone would go bankrupt. So hospitals can't manage that budgetary hit. So what happens when you no longer have that workforce, or the workforce now is what we call travelers, higher cost nurses and providers who travel to hospital, but they garner a higher pay. So if you now have, like, for instance, like one local hospital here has 300 travel nurses, they cost double what a regular nurse would. It's a huge impact on their operating budget. So they're all looking for, how do I get workforce? How do I bring down the cost of care? And I would say the first place to look is your incredibly huge administrative burden. Now, here's a place where AI could really have an incredible impact. Why do we have people reviewing charts when we have NLP and we have AI algorithms that can do all that work, probably better, and take away the administrative cost? The more and more, the millions of dollars you can bring down. So there's 18 to 1, 18 administrators to one provider. Crazy, right? So if we can make that 16, 15, 14 by decreasing the amount of administrators, because the work is now using supercomputers and NLP and LI, then we win. We can have more providers, pay the providers more, and improve overall health care for everybody. So there's hope there. Just one example of a place where we can use science and AI to improve care.
Right, but let's put AI aside for a second. Like, most of the pitches of startup founders I hear, they're like, say, our goal is to reduce cost. Our goal is to improve some processes that eventually is going to reduce cost as well. Do you see, like, even if we're not talking about AI, that any of the startups' technical solutions, they can actually help to reduce cost already?
I hear a lot of pitches too, a lot. and I hear a lot of pitches of solutions looking for an answer without customer discovery. My best piece of advice is get out there and do your 157 customer discovery encounters, and then work on making a pitch with your idea. Because they're trying to find these cool, and I'm a pretty geeky guy. I've been a real guy, write my own code. I've been geek for a long time. I love a good geeky solution. But is it something that healthcare administrators or consumers want or need? And most of the time I find, not really. They're cool, but not really. The administrators are looking for ways to bring more dollars to their workforce or make more money. Currently, with our current state of fee-for-service instead of value-based care, And that means hospitals are still driven by the amount of dollars they bring in for surgical procedures in particular and oncological care. Those are the big drivers of commercial payments. More complex the surgery, the more dollars it brings into the system, the better they meet their budget at the end of the year. It's not value-based, which is where we wanted to go during the ACA or when we were doing that. I was a CMMI researcher, Center for Medicare and Medicare Innovations researcher. We were looking at how we can make it lower cost and higher quality. We're not there yet in the US. We're still in this fee-for-service model, in this in-between weird place. So innovators have to figure out how you're going to pitch to who. Are you pitching to the hospital? Are you pitching to the plan? I was trying to make a case for innovators to pitch to the Medicare Advantage plans because they're value-based and they get it immediately. And they're like, oh, I get it. You're going to bring down costs of my population, especially a targeted population. That makes sense. We're going to invest you as an institutional investment, or maybe we're going to just follow you until you start making some sense or have some good literature behind you. On the consumer side, if you could really figure out a way to get into the market of direct-to-consumer where you have like a $50 visit or a $10 visit that people can afford, and you still get your prescription for a UTI, so you don't have to get a $150 urgent care bill, then that makes sense. Like there's places in the market where you can do, if you do your customer discovery, that you can still get in and really make some good money, I believe.
All right.
And improve care.
And improve care, of course. Again, we started talking about AI a little bit and stuff like that, all that hot stuff that is everyone's talking about. But here's a question for you, from me as a consumer, as a patient. So my family and I, we've been in the US a little over 2 months. So I had to get the insurance plan, find the PCP, get an appointment for the physical, for myself, for my wife, for my kid, then to set up an appointment for a couple more specific doctors. Every time I need to set up an appointment, I need to call and be on the line at least 30 minutes each time. And they redirect me from one person to another, and then maybe I find out that there is no appointment available in the next 2 months, which doesn't work, so I have to go to another hospital and start over again. So I calculated for these just 2 months, I spent at least 10 hours of my life just to set up regular appointments. I understand hospital doesn't really care about my time, but why don't they care about their time and the money they pay to all the administrators that do the job? Why? There's tons of scheduling software that could simplify the process to a couple of minutes for all of us. Why hospitals are still not using just regular scheduling software?
I can answer that question as a cynical answer. I'll try not to, because I worked from within the system. I was a chair of emergency medicine. I was in a hospital leadership team. So I know how the process works. I think that's kind of important to some of your viewers to understand. Like healthcare systems are like Titanic. They can see the iceberg ahead of them, but they can't quickly turn. They're a large bureaucratic entity that even if they wanted to turn to avoid the iceberg, they move so slowly, they're going to hit it anyway. So why don't they use scheduling software? So when I built urgent care centers, we were early adapters of ZocDoc. And if you know, it's a application, a scheduling application, essentially. Was that part of the healthcare system? Actually, no. That was a hard-fought battle for a large healthcare system to allow us to use that additional scheduling methodology because it wasn't fully integrated or accepted by the IT team as a new application. Okay, so we had to literally run it parallel and not integrate it as a solution to bring in patients to make sure we can make our 30 patients per day or whatever number was to keep our head above water. In order to go through the process of getting, for instance, an IT app or an IT solution adapted, you have to go through the whole process. You have to get someone interested from a team, say psychiatry or emergency medicine, be passionate early adapter. They have to advocate with an IK clinical informaticist. That clinical informaticist, I used to be an associate CMIO at a large hospital in New York, has to be, okay, if you really want it, let's get someone to do analytics, to look under the hood. If it's a startup and they have no ongoing funding and they've saved, $40, $50 million, it's nothing, right? They're not in any other large hospitals. They don't have any track record of when they're going to survive or not or have an exit. No large health system's going to say, yes, let's bring them on board. So now you say you have a company that's in 20 hospitals, has a good track record, and you're pitching to a large healthcare system. Okay, let's do an RFP. You have to get someone to write the RFP, request for proposals. To write the RFP, you have to send it out. You have to wait 6 months for responses. You have to evaluate the RFP. You have to get the response. You have to score it and wait to score everybody. You have to bring it to the committee. And that's already another year, right? And then maybe then you might get on a budget cycle, which is once a year. Budget cycles don't happen all year long. One time a year, you have a chance. And if it's a good year, which is no healthcare system right now, because they didn't have any, no one had a good year, maybe Penn, that's about it. You might get through, or you might get line item, literally, I've been through many projects that get line item cut, and you're like, what just happened? I thought we were go, And that's what happens. And explaining that whole process to entrepreneurs who are like, no, that's not true. I'm like, yes, that's how it works. That is just how it works. And, well, we're going to try a different segment of the market. Okay, go for it. Maybe you go for payers. That's an interesting place. Maybe you'll go for the direct-to-consumer. That's an interesting place. But if you're trying to get into the healthcare system market, good luck. It's a long road. It's tough.
So for some startup founder who is working on AI startup right now for a hospital, and he listens to us that there are still not scheduling software implemented, how do we motivate him to get that startup working and to make sure that somebody is going to use it after all?
Well, I don't mean to sound negative. There's hope, and there's planning, and there's really good customer discovery. We here at the Science Center, for instance, have a program called Proof Positive. We go through the ICOR NSF training, and we teach. Literally, I'm a mentor for a customer discovery class, and we teach how to do it and teach the why to do it. And it's fun to watch the companies go through the process and say, oh, I just talked to 10 people and my assumptions weren't really clear. It's the scientific method. It's testing your theory. And you have to learn how to pivot and say what I thought was maybe isn't. And let's go this angle. If you're a company that's working on, for instance, journaling your symptoms for your health care, maybe you think you're in one segment and now you think you're in a different segment. Or now maybe a different segment is a really hot topic for payers, and you have a lot of interviews with payers in the Medicaid managed care space or in the Medicare space, and you say, "Oh, I can answer that with my algorithm, with my solution. Let's go for institutional investors instead of VC vendors, and let's see what that looks like for a while and try doing that." There's lots of ways you can take your customer discovery journey and then move into your commercialization, your capital raise journey, to be able to pivot and to know that that's part of the process of being a founder. You can't be so fixed in your belief and so arrogant with your thought processes that you can't even conceive of changing. It really doesn't work that way in life, nor does it work that way in business. You have to be able to adapt to the change and do a self-check along the journey. And there's lots of success stories. Granted, they're not as many as we would like here at the Science Center. That's part of also what we do is we have various programs along the journey so that we can help you. So that we can say, okay, that sounds good, but let's give you more tools in your toolkit to be able to respond. Let's give you more of a bigger network so that maybe someone you meet can be on your medical advisory board, your scientific advisory board, and they have a connection in a healthcare system. Wow, that's a big step up for me. I really needed that. Or maybe there's a couple of VCs who are investing, for instance, in companies that have a female founder and are really in the women's health space. And that's your niche. And you're working on new ways to treat menopause. Wouldn't that be great? Because there's a big market for that. There's lots of avenues to look at. Don't get discouraged. Just keep working hard and reach out to places like the Science Center that do this work so that we can help you along the way. And there's lots of money too, don't get me wrong. There's federal grants, SBI grants. We have a whole team here that works on that as well. You just need to know about it and be directed into it so that you can rise yourself up and really be successful. It's still America. There's still a lot of opportunity, and there's money to be made and care to be delivered that can really have an impact on people's lives all along the continuum of your life.
That was really important to hear for our audience. Thank you. I really want to ask about telehealth. You know, like it feels like it's been there forever, and COVID kind of made a boost to it. But right now, I think still pretty low percentage of population is using it. What's your opinion about telehealth?
Well, I read an article. I'd have to Google search myself to remember what it was, but it was probably more than 15 years ago. I probably think it's more like 20 years ago, as being an advocate for where telehealth was going. Years ago, I was a stroke researcher advocating for telestroke for rural hospitals so that they could do thrombolytics, which is like blood clot busting medicine, where there's not a neurologist around or an emergency physician who feels comfortable with that. I see great potential to expand the healthcare team by using telehealth and telehealth services, especially for lower acuity issues. The problem is patients don't always know what's low acuity versus high acuity. If you come to me and say, I feel weak, and oh, by the way, I have a little blood in my urine, all of a sudden that changes your history. Is it painful blood or painless blood? It's actually worse if it has no pain than if it does have pain. And then all of a sudden, I'm more interested in seeing you in person in the hospital than I am over the telemonitor. What I think telehealth is great for is that low cost, low acuity care that insurance plans are now really looking at to bring the overall cost of care of their populations down. And for older adults, follow-up visit care, because then as insurance companies really think about whole person care, if they don't have to pay for the transportation to get the older adults to the hospital. I think of my older parents, getting my mom to her appointment is a struggle, a half-day event, versus just a follow-up visit on a screen that she can talk to with someone she's familiar with. Now that's improving quality of care and decreasing costs, right? That all of a sudden starts to make sense. So I don't think it's telehealth for everything, but telehealth for some things, and let's sort it out. Wound care, for instance. The post-CABG or bypass surgery wound, my dad had it, and my mom would take a picture of his wound every day because he didn't want to come to New York City from the Jersey suburbs to have his wound looked at. So literally like what it looks like every day, and we can do that. That's another example of a way we can use telehealth services to improve care, decrease the cost of care, and improve the quality of care. There's a place for it. It's just not everywhere.
Right, but do hospitals, are they interested in telehealth?
Well, hospital-based, it depends on which practices within hospital-based care you're talking about. Psychiatric care, for instance, large institutions went from 5 to 10% telehealth to 95% telehealth during COVID to where are they now? Maybe 80, 85? Still, really, because think about autistic kids. Many years ago, I worked with autistic kids. Getting an autistic kid to an appointment, forget about it. It is really a struggle. The car ride, the changed environment. Whereas you can have an initial evaluation, but then follow-up evaluations by telehealth is a big deal, and there's stickiness in that space. The question is, where's telehealth going to stick? Luckily, in other countries, there's entrepreneurs, for instance, in Australia. We work with a company there. They have a lot of rural areas where they want consultations with secondary or quaternary care. That really helps improve the quality of care. We just haven't sorted it out yet. I think we're going to get there. I remain hopeful in that space. I've been talking about it for a long time. I used to think it was everywhere care, and it's not. I think it was very wrong in that impression that we can bring down the cost of care for segments of populations, and especially follow-up visits.
So looking ahead, where do you see the intersection of healthcare and technology in the next 5 or 10 years?
I think it's hopeful that we can work with startups and companies in the next 5 to 10 years that have an impact on improving not just quality, but decreasing costs. Now, which segments of the healthcare industry that's in? Lower acuity, for sure. I think there'll be a shift to telehealth, for instance, and away from brick and mortar urgent care centers in that lower cost space, because urgent care centers are relatively expensive to maintain the operating budget on it, versus it's much less for a telehealth in that space. That will be an impact. Will there be an impact on hospital at home? I think so. Using home monitoring devices and directly integrating into EHRs will be, in my prediction, in the next 5 to 10 years, much more accepted care at home models, as it is in Israel, for instance. Svar Health and others have really proven the model. And I think it's exciting that the US can look to other countries that are doing things better and say, okay, you're kind of doing it a little better than we are. Let's adapt some of that for hospital at home. There's recently in the news, a large hospital in Massachusetts is making a huge investment in hospital at home. I think the entrepreneurs in that space will be, in my opinion, the good ones, will be a good investment in the next 5 to 10 years. I also think that there'll be a sorting out of the behavioral and mental health services investments that were made during COVID. There was a large spike in investment in that space. I think we'll see where the Series A, Series B fundings are going to go based on results, and not just because it sounds good. It sounds good to help people who are having mental health problems, but we need it to not just sound good, but we need to actually prove that it has an impact and an effect on improving lives and sustaining populations who are either have anxiety or depression or substance use disorder that can keep them on the track where we want them to be. Not just with fancy AI technology, but sometimes text messages with integrated, or maybe voice recognition, which is a really cool space, voice recognition for depression or anxiety. How can we use the AI algorithms to better identify the needs of populations of patients? It's kind of cool, but can we prove that it actually has an impact on decreasing costs and improving quality of care? Once we get into that space, as a scientist, I always push the startups like, you need to study. We need to have preferably a double-blinded placebo-controlled trial, if not at least, 2 cohorts of patients in a really well-designed, not a great design, but a good design study, that we have some literature, some data. We're not just pitching an idea to a market that doesn't want to just hear ideas. We want ideas that are backed up with some results. But there's hope.
There's hope. Finally, you already gave the most important advice is do the research, talk to your audience, to your target audience before you start developing anything. Maybe anything else you can recommend startup founders when they try to enter this market, what they need to do or not do in order to be successful?
I think they need to put in the work. The ones that I'm finding that are successful are the ones that are really all in. That's a very hard thing to do when you're working another job. And it's really, years ago when I started my software business, what I learned, I didn't have enough capital and I didn't have enough time. And it's the same lesson today. If you don't have enough capital, if you don't have enough savings or early friends and family investment, bootstrap investment to fund yourself for 1, preferably 2 years, don't even start. You're just going to waste your money and you're not going to get anywhere. You need to do your customer discovery. Actually do it. Don't just, I talked to such and such. No. Do it, record it, document it. I actually had one of my companies say they were putting all their interview notes into ChatGPT to see if they can get a trend out of it. Like, interesting. That's not exactly what I told you to do. You're not going to get closer to 157 by analyzing your first 20. You may get trends, and you could use that along the way. But I thought that was a interesting way of taking what I said into something I didn't say. I don't think there's any shortcuts. I think there's hard work, just like anything else in life. It's do the hard work, and you can succeed. And don't be discouraged. Have a good story. Life stories really help when you're down. And be able to pivot, and be able to listen and really hear what's being told to you, I think is my best bits of advice.
Thank you, Kevin. I think that was really important to hear. Thank you for this amazing interview. Hopefully people get a better understanding how American healthcare system works here.
All right. Thanks, Alex. It's been really fun.
Thank you.